This is a fascinating patient that had cyanosis of the lower extremities. Marked cardiomegaly was observed and prominence of the pulmonary vasculature, particularly in the right upper lobe. There was also hyperinflation of the study of the left side of the heart showed the aorta giving rise to a right pulmonary artery. However, the pressure in the right pulmonary artery was lower than the pressure in the left. Note that there is a small structure that is noted to the left of the aorta that could represent a small left pulmonary artery or less likely a ductus arteriosus. A late phase of this injection shows that the right base was supplied by a systemic artery coming off the lower descending aorta. This area of the lung had systemic arterial supply without the bronchopulmonary sequestration. Note the gradual tapering of the branches of the right pulmonary. A late phase of this injection shows uniform opacification of the right pulmonary veins that filled the left atrium. Selective injection of the left pulmonary artery showed that there was poor peripheral perfusion of the left lung and no opacification of the descending aorta. This means that the patient has a right to left shunt at the level of the ductus arteriosus. Of interest is that the patient had lower extremity cyanosis and the upper extremities were not cyanotic. A late phase of this injection shows persistent visualization of the pulmonary arteries and poor visualization of the left atrium. This patient had a higher pressure in the left pulmonary artery than on the right, although the right arose from the aorta. And the reason for that was that at post-mortem examination, there was evidence of intimal hyperplasia and muscular hypertrophy of the left pulmonary arteries, although they were not the ones that received systemic blood supply. So this is an unusual case of cyanosis of the lower extremities in a patient who had pulmonary hypertension of the left lung due to a congenital abnormality of the intrapulmonary arteries.